Hello. You have to wait a year before starting progesterone, and you have to stop it in 2 to 5 years. I hear both those claims constantly, or I see them on the internet. Neither is an evidence based universal rule, but that doesn't mean progesterone is magic or completely risk free either. Let's separate what we know from what we don't. I'm Dr. Dave, your transgender health and hormone specialist, and I've been doing this for 30 years. Let's talk about it. First, an important vocabulary lesson. Progestogen is the umbrella term. It includes natural progesterone and synthetic medications called progestins. Medroxyprogesterone acetate, or Provera, is a synthetic progestin. Micronized progesterone is chemically identical to the progesterone produced by the human body. Micronized simply means it has been processed into very small particles so your body can absorb it. These are not interchangeable molecules, and they shouldn't automatically be assigned identical benefits or risks. Much of the fear surrounding progestins came from the Women's Health Initiative, which studied older postmenopausal cisgender women taking conjugated equine estrogen combined with medroxyprogesterone acetate. That was a completely different population, a different estrogen, and a different progestin from what many trans women use today. We also can't honestly claim that medroxyprogesterone alone caused every risk found in that study. It studied the combination. Research in cisgender women suggests micronized progesterone may have a more favorable cardiovascular, clotting, and metabolic profile than some synthetic progestins, but long-term safety data, specifically in trans women, remains limited. Different does not mean completely risk-free, however. Now, when should progesterone be started? There's no high-quality evidence establishing a mandatory 1, 3, 6-month, 1 year waiting period. Some providers are willing to start it immediately. Some wait until estradiol has been established, testosterone is controlled, or breast development has reached a certain stage. That approach comes partly from theories about cisgender puberty and concern that introducing progesterone too early might alter breast development. All of that is false, and no study has demonstrated that starting progesterone early harms or limits breast growth in trans women. I don't treat a theoretical concern as a biological law. I discuss the uncertainty, the person's goals, and the potential benefits and side effects. And then we together make an informed decision. There is one important limitation. The most encouraging randomized studies so far involve people who had already used estradiol for at least a year and had undergone orchiectomy or vaginoplasty. It therefore cannot tell us whether starting progesterone on day one is better, worse, or equivalent. There is no proven perfect starting time and no evidence-based gate everyone must pass through. Now let's talk about how it's taken. Oral micronized progesterone is the most common and best studied route. Doses are individualized, but 100 to 200 milligrams at bedtime are commonly used. When swallowed, much of it's converted by the liver into neuroactive metabolites, including alpregnolone, that can cause relaxation, sleepiness, dizziness, or a slightly intoxicated feeling for some people. That's why it belongs at bedtime and not driving to work. Some people sleep better, others feel groggy the next morning, have vivid dreams, or notice no sleep benefit at all. Rectal administration is also used, but it's off-label in many countries. It partly avoids that first pass liver metabolism and may produce higher or more sustained levels of progesterone itself. But here's the crucial point. Higher blood levels do not automatically mean better feminization. We do not yet have good studies showing that rectal progesterone produces better breast development or other outcomes better than oral progesterone in trans women. Absorption can vary, and not every oral capsule is manufactured or approved for rectal use. So rectal administration is a legitimate clinical discussion, but it's not a proven secret upgrade that you hear online. I'd also be cautious about assuming that vaginal administration after vaginoplasty works exactly like vaginal progesterone in cisgender women. Neovaginal tissue differs depending on the surgical technique, and we have not had adequate absorption or outcome data. Progesterone creams are another story. Skin absorption is inconsistent, and they do not reliably produce the systemic exposure achieved with prescribed oral or rectal formulations. I would not consider an over-the-counter cream at all. It's definitely not an equivalent substitute. And there's also no evidence that trans women need to cycle progesterone for 10 or 14 days every month. Some people prefer cycling, but it can create reoccurring changes in mood, sleep, or breast tenderness. If progesterone is used, continuous nightly dosing is the most common use. So does progesterone actually improve feminization? The evidence is evolving. A small 2022 study using 100 micrograms orally for 3 months found no significant group level improvement in breast tanner stage, sleep, or psychological distress, but it was small, used a relatively low dose, and followed people only for 3 months. Then, in 2025, researchers presented the first randomized trial involving 90 participants. After 1 year, groups receiving micronized progesterone showed encouraging increase in breast volume and greater satisfaction, particularly in some of the progesterone and estradiol combinations. That is genuinely promising. But the participants had already used estradiol for at least a year, had undergone gonadectomy, and the complete results still require full peer-reviewed publication and longer follow-up. A large 2025 survey also found that many trans people perceived improvements in breast development and their sense of femininity while using progestins. Patient experience does matter, but a survey cannot prove that the progesterone alone caused those changes. In my practice, patients have reported greater breast fullness, better sleep, changes in libido, improved mood, and sometimes they just feel more settled in their bodies. Others notice nothing, and some, it's rare, but some feel worse. Possible side effects include sleepiness, dizziness, breast tenderness, increased appetite, vivid dreams, and mood changes. If depression, anxiety, or irritability become significantly worse, the medication should be reassessed, obviously. Some progesterone capsules also contain peanut oil, so check the specific product if you have a peanut allergy. And there is no validated progesterone blood level target for trans femme care. Chasing a particular number, especially after oral dosing, has not been shown to improve results. Finally, let's address that 2 or 5 year myth. There is no evidence-based rule requiring a trans woman to stop micronized progesterone after 5 years. That number is carried over from the discussion of menopausal hormone therapy and duration-related breast cancer risks, particularly studies involving estrogen combined with synthetic progestins such as medroxyprogesterone. Those findings simply cannot be copied onto younger trans women taking estradiol and micronized progesterone. There is no automatic time limit, but that doesn't necessarily mean it's proven safe forever. The current approach is individualized treatment, appropriate breast screening, and periodic reevaluation of whether the progesterone is providing enough benefit to justify its continued use. And here's the truth. Hopefully, I'm always giving you the truth. Progesterone is optional. It's never required. There is no proven mandatory waiting period. There is no fixed X number of years expiration date. Oral progesterone is the best studied route. Rectal progesterone may produce different hormone levels, but it's not been proven to work any better. And the evidence for breast development is now encouraging, but nothing yet definitive. That's informed consent, not pretending we know nothing or we know everything. The more research we have, the better support we get. If someone has given you an absolute rule about progesterone, ask them 2 questions. Which molecule are you talking about? Are we talking about bioidentical or synthetic? And what evidence support that rule? You'll find they don't have any. Thank you for your support and hitting all those buttons. It means the world to me. We'll talk soon. Love, support, and protect one another. Meow.